You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about anatomic testing. We'll talk about CAC, coronary artery calcification scoring. Then we'll move on to CCTA, coronary CT angiography. And then we'll wrap up the discussion on stress testing started from the previous episode by going over the trade-offs of functional stress testing versus anatomic testing. And then we will finish up by talking about principles that run through across all modalities. Starting with CAC in outpatients. According to the 2019 AHA-ACC Primary Prevention Guidelines, adults 40 to 75 years of age without diabetes and with LDL between 70 to 189 with a 10-year ASCVD risk between 7.5 and 19.9%, coronary artery calcium scoring can inform the decision regarding statin therapy. If CAC is 0, treatment with statin therapy may be withheld or delayed, except in cigarette smokers, those with actual diabetes mellitus, and those with a strong family history of premature ASCVD. A CAC score of 1 to 99 favors statin therapy, especially in those of at least 55 years of age. For any patient, if the CAC score is at least 1,000 Agaston units, statin therapy is indicated. CAC scoring is unique in that it is able to distinguish patients who are at such low risk that statin therapy may not be beneficial. CAC scoring has a higher net reclassification improvement compared with other novel risk factors such as carotid intima media thickening, ankle brachial indexes, apolipoprotein B, and high sensitivity C-reactive protein. Biomarkers associated with increased ASCVD risk include high sensitivity CRP of 2 or more milligrams per liter, serum triglycerides of 175 or more milligrams per liter, lipoprotein A more than 125 nanomoles per liter, and apolipoprotein B of at least 130 milligrams per liter, or ankle brachial index less than 0.9. Revascularization does not confer mortality benefit in asymptomatic patients. So, if a patient who has a high-risk CAC score is asymptomatic and has no ECG changes, neither coronary angiography nor CT angiography is recommended. Just add a statin. Now let's move on to CAC in ED patients and inpatients. The 2021 AHA-ACC guideline for the evaluation and diagnosis of chest pain states, for patients with stable chest pain and no known CAD categorized as low risk, CAC testing is reasonable as a first-line test for excluding calcified plaque and identifying patients with a low likelihood of obstructive CAD, Class 2A. When a patient presents with chest pain and has a prior CAC or prior CT scan, the 2021 chest pain guidelines say, when available, information on the presence and amount of coronary artery calcification may be useful for enhancing the pretest probability of obstructive CAD. This information can be obtained from performing a CAC scan or, when available, from a visual estimation of CAC based on prior non-cardiac chest CT. Among symptomatic patients, a CAC score of 0 identifies a low-risk cohort of patients who may not require additional diagnostic testing. Most events occur among patients with detectable CAC. Nevertheless, there are some limitations to CAC. It does not detect non-calcified plaque, so a CAC score of 0 does not completely rule out CAD. It is less informative in younger patients due to a lower likelihood of calcification at an early age. That's all for CAC. Now we'll move on to coronary CTA. Coronary CTA provides better anatomic resolution than nuclear stress tests, although it does not provide functional data that perfusion imaging does. Coronary CTA can distinguish between calcified, non-calcified, and mixed plaques, and can assess plaque burden. High-risk plaque features, such as those with low attenuation or positive remodeling, can identify patients at increased risk of events. Although coronary artery calcification is a surrogate marker for coronary atherosclerotic plaque, the correlation between the amount of coronary calcium and the actual angiographic severity of the CAD ends up being weaker than we'd like. Situations where CCTA is inaccurate are as follows. Severe coronary calcification. High calcium burden can cause beam hardening artifacts, limiting the ability to assess stenosis. High heart rates, irregular or fast heart rates can lead to motion artifacts. Other arrhythmias. Poor temporal resolution can degrade image quality. And obesity. Excessive body mass can affect image quality and limit resolution. The two most common scanning protocols for CCTA are prospective, that's prospective ECG gated or step and shoot, and retrospective ECG gated. In prospective ECG gated scanning, images are acquired only during diastole. That's ideal when you have a patient who has a very well controlled heart rate, less than 60 beats per minute. Prospective ECG gated scanning gives you low radiation exposure, although with limited temporal coverage. Retrospective ECG gated scanning does continuous imaging throughout the entire cardiac cycle, allowing for multi-phase reconstructions. It comes at a cost of higher radiation dose, but enables evaluation of coronary motion and ventricular function. Now, how about FFR-CT? Fractional flow reserve from CT works by using computational fluid dynamics to simulate blood flow through coronary arteries based on the anatomy from a coronary CTA scan. The software analyzes the coronary lumen geometry and uses blood pressure and flow physics to estimate how much blood stenosis affects blood flow under simulated conditions, similar to what adenosine does during invasive FFR. According to the SCCT 2021 Expert Consensus document on CCTA, it may be appropriate to perform CT-derived FFR and CT myocardial perfusion imaging to evaluate the functional significance of intermediate stenosis on CTA, which they define as 30 to 90% diameter stenosis, particularly in the setting of multivessel disease to help guide ICA referral and revascularization treatment planning. However, they note that left main stenosis of 50% or more and severe triple vessel disease are situations where you should undergo invasive coronary angiography and not just rely on FFR-CT. In general, adding FFR-CT and stress CTP to coronary CTA increases specificity, positive predictive value, and diagnostic accuracy over regular CTA without the FFR-CT component. What are the situations where FFR-CT is inaccurate? Severe coronary calcification. Calcification affects pressure gradients and leads to inaccurate FFR-CT measurements. And small arteries. FFR-CT does not perform well in vessels less than 2 millimeters in diameter. Is it okay to do coronary CTA if there's a prior stent or prior CABG? Well, according to the SCCT 2021 Expert Consensus document on CCTA, it is appropriate to perform coronary CTA in symptomatic patients with intracoronary stent diameter of at least 3.0 millimeters. Measures to improve accuracy of stent imaging should be utilized to include strict heart rate control with a goal of less than 60 BPM, iterative reconstruction, sharp kernel reconstruction, and monoenergetic reconstructions where available. Protocols to optimize stent imaging should be developed and followed. It may be appropriate to perform coronary CTA in symptomatic patients with stents less than 3 millimeters, especially those known to have thin stent struts less than 100 millimeters in proximal non-bifurcation locations. They also say it is appropriate to perform CTA for evaluation of patients with prior CABG, particularly if graft patency is a primary objective. Now let's go over CCTA artifacts. Motion artifacts are caused by cardiac motion, especially when the heart rate is high or irregular. It's mitigated by using beta blockers to lower the heart rate or using prospective ECG gating. Beam hardening artifacts occur from dense structures such as calcium or metal, causing streaks or dark bands, often seen in heavily calcified arteries or near stents. Stair-step artifact results from misalignment of images in multi-segment reconstruction, often when heart rate is variable. Blooming artifact is caused by overestimation of the size of calcifications or stents due to partial volume effects, making the lumen appear smaller than it is. Now it's time to talk about the trade-offs of functional stress testing versus anatomic testing. Things that favor coronary CTA, so that's anatomic testing, are when you have a goal of trying to rule out obstructive CAD and detect non-obstructive CAD. When your patient's age is young, less than 65 years. When your pretest likelihood is low to intermediate risk of having obstructive CAD. When you have a prior functional study that's inconclusive. Also, if you have other indications like needing to evaluate anomalous coronary arteries or aortic or pulmonary arteries. On the other hand, factors that favor stress testing are as follows. If your goal is ischemia-guided management, if your patient is older, of 65 years or higher, if your pretest probability of obstructive CAD is high, or if you have a prior CCTA that's inconclusive, or if you have other indications, for example, if you suspect scar or microvascular dysfunction, then you may want to use PET stress testing or cardiac MRI. The final part of this episode, we will discuss principles that hold across modalities, both stress testing and anatomic. The 2021 chest pain guidelines state that the warranty period of prior cardiac testing should be considered when symptoms are unchanged. A normal coronary angiogram has a warranty period of 2 years. A prior normal coronary CTA with no stenosis or plaque has a warranty period of 2 years. A prior normal stress test, assuming that there was adequate stress, has a warranty period of 1 year. Across modalities, high-risk features, which are features associated with more than 3% annual risk of MI or death, are as follows. The Duke treadmill score of less than -10, specifically more negative than -10, having ST depression of more than 2 millimeters at low workload and into recovery, exercise-induced VT, VFib, or ST elevations, ischemia on nuclear stress testing of at least 10%, which is more than 2 segments, or in at least 2 separate coronary territories. Stress wall motion abnormalities in at least 3 segments or 2 coronary territories. Stress wall motion abnormalities at low dose dobutamine or low heart rate of less than 120. Stress-induced LVEF of less than 45% or a 10% drop. A stress-induced LV dilation, also known as transient ischemic dilation or TID. A CAC score more than 400. Left main stenosis of 50% or more on coronary CTA. And multivessel disease, usually 70% or more each on coronary CTA. If you have any of these high-risk features, then you need to go to invasive coronary angiography. If your imaging stress test only has low-risk features, meaning features associated with less than 1% of risk of MI or death annually, you can't say it is low risk if there are any of these other factors. LVEF less than 35%, diabetes, renal failure, high-risk Duke treadmill score, or occurring at low-level stress or heart rate. When obtaining informed consent from patients for stress testing, you can note that stress testing is relatively safe. There's a less than 0.01% risk of sudden cardiac death, a less than 0.04% risk of acute MI, and a less than 0.2% risk of hospitalization, including for arrhythmias. And that's all for anatomic testing and trade-offs of functional stress testing versus anatomic testing.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.